Hello, everybody, and welcome to our 12th episode of Agree to Disagree About Gender. I'm Laura Tregonik.
And I'm Yvette Neri.
And I'd like to welcome you to today's episode. So it's been an exciting week in the news. There's a very brief something I just thought maybe before we bring our guest in, because I know a lot of people have been talking about it, and both Yvette and I have been engaging in a little bit of online debating about it. Although once again, one of these areas where we probably agree to agree more than we agree to disagree was about the recent ruling of the International Olympic Committee that came down this past, I believe it was a few days ago, or I don't know how many days it'll be by the time we release it, but basically recently, where the IOC has basically confirmed, which I think a lot of people suspected was the direction that they were going to go in, that they are going to be using, they've developed a protocol for screening athletes who are registered to participate in female sports to basically identify and restrict entry to anyone who is natally male or biologically male, or specifically anybody who has, if you want to get really into the details, people who both have the SRY gene, which is a gene that's on the Y chromosome. That is a fairly good sign both of your having a Y chromosome and your ability to make the gametes associated with the Y chromosome, and also who, as a result of that, either have been or will have been exposed to elevated levels of testosterone that convey what I think you and I both agree on is a considerable competitive advantage in the number of sports. So I guess the main controversy, like anytime sports issues comes up, has been, this balance of competitive fairness and inclusion and protecting a women's category for a certain class of people versus the consequences of imposing a testing regime back on female athletes and the consequences of things like false positive tests potentially or invasive screening. So what are your thoughts on that part of the argument? Because I know the main thing that I think even reasonable trans people sometimes will object to is going, and by reasonable, I mean people who, like myself, can acknowledge that there is a biological advantage generally to having a Y chromosome, especially if you have gone through male puberty in whole or in part. That is not fully, in my opinion, or at least my understanding, is not sufficiently reversed by estrogen therapy to reduce those competitive advantages. So we agree on that, but we also recognize that things like there's going to be there may be false positives, and there's the potential for those people to be labeled as cheaters or as men who either they don't identify that way or maybe are actually not male. And then all the other women who have to take on the burden of having these tests, even the screening tests. So what's your take on this, Yvette? Because I know you follow this issue quite closely.
Right. My understanding is that it's a one-time screening, that, no athlete is being screened again and again and again and again. And
once you have your gene for life, you don't.
Right. But for people, let's say, who, for whatever, like, I don't know what a false positive would be, other than CAIS, complete androgen insensitivity syndrome. I don't know, as a group of people with no androgen sensitivity, that this is really a conversation in elite sports anyway. To be honest, I don't know. You lose an edge by having no testosterone at all, or that you can't use it at all.
Yeah, like
even like CIAS, I don't consider an ultrasound that invasive. All you need to do is find testes or have history of testes being removed, internal testes.
Yeah.
Or to look and double check and, yep, there's ovaries, there's a female reproductive tract.
But to look in that area, to be fair, may require a vaginal ultrasound, and many people who have DSDs have, it may not be a full female reproductive tract, but have a vagina. Just because of the location of the gonads and, people's different body types, sometimes you can see them just looking through the front of the pelvis, but sometimes,
But we're talking athletes. We're not talking people who are morbidly obese.
No, you're fair. Yeah,
we're talking people with very, very little body fat.
That's probably generally true for most sports.
Oh, except for sumo wrestlers, and that there's not a
But yeah,
women's
sumo
division.
wrestlers, but even women wrestlers, weightlifters,
Right, but they're not going to be very large people. They're not going to have a lot of fat. They're not going to have a lot of, you're not going to be doing an ultrasound. They can find my kidneys with no trouble.
Yeah.
They're not counting, maturing eggs in the ova. They're just looking, my thought is it really can't be that big a deal. It can't be that insurmountable. And it's not repeated.
Yeah. So I agree with a lot of that because you're right. It's a one-time test because even if you're someone like me, your gene doesn't, we all recognize our genes don't change. I still have the SRY gene, presumably. I've never been tested, but I presume if I was tested, I would test positive. So it's not like people have to be screened for every time. You get a barcode or a QR code that basically says it. And if you don't lose that, then you don't have to be tested again. So it's like having a passport or something similar. I guess my concern is that because there are going to be some false positives, because no genetic test, even when run, sometimes just mistakes get made, things get processed wrong. There's contamination. There's some people have a small amount of male DNA. Even natal women who have mild mosaicism might have whatever 5% of their genes having this, but they're still natally female, genetically female. They can reproduce. They have no competitive advantage. And my fear is often we see like these tests being leaked and people's names get tarnished, who it turns out even on secondary testing might test normal, but there's still this stigma that sort of hangs over them for that time being of cheaters, and maybe someone paid off someone to let the secondary. We've all seen these rumors kind of circulate when these things come out, and sometimes rumors are true and sometimes they aren't, but people tend to remember the rumor more than the truth. And then the other criticism is that just by the way that a lot of DSDs don't get diagnosed for the escape detection, especially in places where they're not as economically developed, where people don't have access to medical care. You have a population that maybe, hasn't received the same, because the infrastructure hasn't received the same level of education around sexual development, and where these children may be raised as women and socially see themselves as women, and then learn during their adolescence when they don't get a period or when they don't develop properly, into a phenotypically female body, as is the case with probably the most common DSD that we see of 5-alpha reductase deficiency. This is the one that Amana Khalif is, strongly rumored to have. That, these people, I agree, have competitive advantages and probably shouldn't be there, but the amount of hate, and these people, often they get.
I think the hate that Khalif was getting was not because Khalif had a DSD, but because Khalif really does look male. Moves like I saw, photos and videos.
She's biologically or physiologically, like she's got a lot. Like I'm saying, if you give someone 50 years of testosterone, that's how their body's going to.
Right. And if the women's category had been respected, if you have internal testes and, you are, and your body can respond to it, that's not female for the purposes of sports. If in this person's village or, where they're from, if everyone accepts that Khalif is a woman, okay, that's great. But we're talking about elite athleticism, not the social aspect of it.
There's no debate for me there that she had advantages. I'm not saying what from wherever she would have been if she didn't have testosterone, she was better for it. But what I see, what I'm probably more referring to is a lot of the people who, she's living as a woman, whether she should be or not, or whether, she's living as a woman, that's her identity. If it changes down the road, we'll learn about that later. But even though she's maybe has masculine features in her body or maleness, that's obviously coming through. She's
male.
She lives as a woman, and a lot of it has been sort of this denial of identity on something like, I think it's something.
But that's not relative. That's not relevant to elite sports.
it isn't relevant to
Identity
elite
is
sports,
not.
but what I'm saying is it spills over into her personal life.
If
Like
she
I'm
were not
perfectly,
competing in the women's division,
yeah.
she wouldn't have gotten any flack. There wouldn't be any hatred. There wouldn't
I,
be, if she were competing in the men's,
yeah,
no problem.
yeah. I think she's more or less, she's not going to be competing further. She's now a private citizen. She's, but there's still sort of this move to really, I guess, invalidate her identity. Even so,
Why is her identity important in the topic of elite sports?
it's not important in the top of elite sports. It's just how she's treated as a person. And a lot of the people have been like, I read the comment sections and I read the discourse, and a lot of the people are not just criticizing her for participating in sports, which I think is fair criticism, given her physiology. But I also think they're critiquing their, but I think by saying this person, like I recognize we get into a lot of debates around language. Is this person male? Is this person a man? But that almost like it's unfair. I think she's almost being subject to criticism for identifying and continuing to live in the female role independent of that. But that's just, like I said, that's my take on it. And we may agree to disagree. Yeah. So, I just thought it would be good to talk about that. But really, what we're always here for is for our guests. And Yvette was able to find us our next guest today because you met her at the
At the GenSpec detransition conference in Washington, D.C.
Yeah.
Earlier this month.
Yeah. And so the reason we wanted to have her on, and we're going to bring her in right away, is that she is a physician like myself. She is in a specialty that's actually a little bit similar to myself.
Your neighbors.
Yeah, we're neighbors. We're in the same geographic neighborhood. So I am a gastroenterologist. I work on the intestines and the rectum, so more towards the back end. And her surgery is more towards the front end. She's a pelvic and urogynecological surgeon. So she's dealing with, I think, practice primarily female-centric women who have pelvic floor dysfunction or who need reconstruction after, let's say, cancer surgery. So very important work. But she has found her way to become quite skeptical as well of gender affirming care. And I guess particularly given her area of expertise in terms of gender affirming surgical care, which is something that I wanted to talk about her because she's someone who's obviously going to be fairly well read on this, even though from what I understand, it's not part of her practice. She doesn't perform these kind of surgeries. I think she might have some training or some understanding of it. So, I think it's always great to bring on knowledgeable people with expertise, but who might think differently than myself, and obviously might think Yvette can speak for herself, obviously, in terms of what your understanding of her position is.
Right, and we will agree to one extent and disagree to another.
Yeah,
which is fine.
I think, as is often the case with us. So I'm just going to bring her in and we'll introduce her and then get into talking. So, I guess part of introducing on most shows is you say the person's name, correct?
Mm-hmm.
This is pretty standard practice?
Yes.
Yes. Okay, because I don't think I've done that yet. So, our guest is Dr. Melanie Crites Bachert. Melanie Crites Bachert. Let's bring her in and we'll redo the introduction. So, as you can see, we've been joined by Dr. Melanie Crites Bachert. Dr. Crites Bachert is our guest today, and as we were talking about in the initial intro, the reason we wanted to have her on is because she's a physician who has expertise particularly in surgery in the urogynecologic area. So just to give you a little bit of background of who she is and why we're having her on. So Dr. Crites Bachert you're a doctor of osteopathic medicine. You're board certified by the FACS, and you're a highly skilled urologist and pelvic reconstructive surgeon who has been adept at surgically treating complications from previous mesh surgeries. I understand that you ran the premier pelvic health center in Portland, Oregon, and you now serve in private practice where you've taken your expertise, and that your primary specialty is in pelvic and urogynecologic surgery. So doing maybe even before I get into the rest of the introduction, maybe just tell us a little bit of what that is, because I have an idea, and maybe some of our viewers might not.
Yeah, sure. So yes, I am an osteopathic physician, so I tend to practice very holistically. Okay. I stick to my traditional osteopathic roots. But I am also a board certified surgeon in urology. And beyond that, I did fellowship training beyond my residency in pelvic reconstruction. And so that is reconstruction of the male and the female pelvis. So not one or the other, reconstructing both. And my fellowship was the one that you did back in the day before there became transgender fellowships. Those have only been in existence 7, maybe 8 years. And so if you wanted to go into pelvic reconstructive surgery for transgender surgery, my fellowship is the one that you originally did before this ever became a thing.
So yeah, so a lot of the surgeons who do this kind of surgery are similarly trained to you, and I'm presuming as part of your training, even though it might not be part of your practice, you were exposed to these types of surgeries, correct?
That is correct. Plastic surgeons, to some extent, can attempt to do these surgeries, but it's more for cosmesis, cosmetic purposes. But plastic surgeons can sometimes do some of these procedures. But we are traditionally the ones that should be taking care of the plumbing.
Yeah, because you've got a good understanding of how the plumbing's supposed to look, and
That's
when it's not
correct.
looking quite right, and how to make people whole again. Is that a lot of what you do?
Correct.
Yeah.
That's correct.
And this is often after sort of cancer, after radiation, after injuries, all those kind of things.
All those sorts of things. And sometimes individuals are born with some sort of pathological condition. So, for instance, the bladder is on the outside of the body. These are extreme cases, of
Yeah.
course, but, sometimes young boys are born with what we call posterior urethral valves, and that can create backup in the urinary system, backup of urine into the kidneys, and causes them to retain urine. So, you have to reconstruct those sorts of things. Sometimes as a result of infection or trauma or cancer, individuals can develop strictures, which is a narrowing of the urethra, preventing urine from effectively passing out of the body.
All right.
So
So
that's a
obviously
nutshell.
critically important work, life, if not life-saving, life-changing work. I think we can agree on that. These are surgeries where people are having, whether it's congenital things like you describe or other injuries where people are having significant dysfunction that maybe isn't going to kill them, but is going to cause significant suffering and significant impacts on quality of life. And you do these types of surgeries that obviously make a big difference to people. But people are very satisfied, that are difficult, but people are very satisfied with. Would that be sort of fair to say?
Generally so.
Okay. So I guess the reason that we having you on, like, it's obviously great to have people with expertise, but we're a show about gender, and we're particularly a show that talks about some of the contentious issues, particularly around trans people in society, about medical management, medical and surgical management of people who are trans, or people who have gender dysphoria or seek out these surgeries for other reasons, and so I want to just turn it over to Yvette, because obviously you and her met somewhere, and obviously that's how we sort of came to know you. But maybe I just want to understand from her and from you how it is that you came to be here today.
Well, we both attended GenSpec's detransition conference in Washington, D.C. earlier this month. And we just happened to sit down, next to each other and started talking. And it was a really, you'll need to trim that out. It was a really excellent conversation, and we share many points of view and many concerns, especially with the transition of minors.
Yeah. Okay. So you both met at the GenSpec. This was back on, I think the date was
March 12th.
Yeah. In Washington, D.C., where GenSpec, who I think most of our viewers understand, is a group that is primarily focused on reducing, I don't want to mischaracterize their mission, but they're solidly in that trans, that people should not, or especially for young people, that there are better options available for people who are predisposed or who desire this type of therapy than to pursue medical and surgical interventions, and are obviously doing a lot of advocacy and supporting research, maybe not supporting research specifically, but doing a lot of advocacy to promote that point of view.
Right.
And as well as people who are, here, you tell me.
Yes, and to create resources for people who have detransitioned because they have nothing. Yeah. They're just now trying to get some ICD codes. Yeah. You can't even say, oh, detransition is 1%, not that you do, but a lot of people do. You can't track it.
Yeah.
When someone needs mental health support or like breast implants or whatever they need, or some corrective surgery, there's no detransition code.
Yeah.
And so they're missing resources, and then there's not insurance code tracking.
Yeah, and I know we've talked on a previous show about that I think that's actually a really good idea. That there should be a detransition code, and there should be a way to more effectively track it, so we're not kind of all making our best guesses on how often people do detransition after pursuing a gender transition to different extents, and how many people don't over a long period of time. So I think for just because I'm a research first and a data first person, I'm particularly a data quality first person, that having those codes is going to be a huge boon, I think, to both sides of the debate, to be honest. And
most importantly for the people involved.
Yes.
Like, the debate is the debate.
Yeah.
But if we can track who is desisting and what are the needs of people who desist, and who is detransitioning and what are their needs, then we can have a better conversation all around, and the people who have needs can get services.
Yeah. And I agree with sort of a big part of that. Like, we know that even if you could design a system that is optimal, there's always going to be some people who need this care, and those people are, we talked about this before, how whatever surgery you do, and I'm sure this applies to you too, is that complicate, even under the best care, and even with the best people, and even with your best patients, complications occur. Sometimes people have regrets about things that were done with the best of intentions, and as physicians, we try to be responsible for not just our good outcomes, and obviously we're very proud of our good outcomes, but also with our not so good outcomes when they do occur, not because of negligence or malpractice, but just because sometimes bad things happen, even when we're trying to do our best. So I want to bring the conversation back to you, doctor, in terms of was it, obviously I recognize that you had training in this. This wasn't part of your practice, correct? Yeah. So how was it that you became sort of interested in this topic again? What was your exposure to it in terms of, because obviously you become an advocate here, you're at the Genspec conference, I've seen some of your videos. How was it that you came to sort of prominence, or how did this begin to animate you?
So I actually experienced patients seeing me in the office for things that they were being referred for, and conditions they were being referred for, that actually ended up being a result of the medicalization process of all of this. Excuse me. So patients were coming in not understanding what was going on with their bodies, coming in with particular complications of different things. And the thing that was most appalling to me is that the providers giving them and providing the medicalization also did not fully understand what they were doing, because if they did, they would have properly educated and informed these patients. These are things that are potentially going to happen. And if the provider didn't, for instance, cover everything in the beginning.
Can I stop? I just want to make sure everyone understands. I think I get what you're talking about, but specifically, what kind of things are people coming in with?
They were coming in for things like chronic pelvic pain, changes in their bodies as a result of cross-sex hormones, and they were not being given true informed consent. And the reason I know the providers also didn't know what they were doing was because if the patient comes back to you and says, I'm having this condition, this is what's going on, the doctor and the provider would have been able to counsel that patient. Oh, yes, this is a result of testosterone on your body. This is so, for instance, I had a patient that was referred to me for chronic pelvic pain. Well, the provider that was providing the testosterone sent the patient and referred the patient to me because the provider didn't know what to do. The provider didn't know what was going on. And it took me just a little bit of time of seeing the patient as a new patient, examining the patient, to find out that this female that was being medicalized and given high doses of testosterone to present as a male was actually having not chronic pelvic pain, but was having manifestations of morning erections. So essentially, the clitoris had enlarged so much that in the morning, which is a normal physiological process of men, that's a normal physiological process caused by testosterone. So what was absolutely appalling to me was I explained this to the patient, and the patient understood what was going on, so could kind of wrap their head around what was going on with their body. But what was absolutely appalling to me was the person providing the testosterone had no clue what was going on, nor did that provider even examine the patient.
Yeah. So these are just for clarity, these are primarily that you're seeing natally female patients primarily who are being placed on testosterone. Now, are you seeing pediatric patients? Are you seeing adult patients mostly?
No, it's mostly adult
Mostly
patients.
adults, some young adults, and so you're seeing people who have presumably been diagnosed, presumably, but I don't want to, we shouldn't maybe presume too much, but these are people who physicians felt were going to benefit from testosterone therapy. Testosterone is a drug that does things. It's a biologically active drug. It does many, many things in the body, including some of the things that you described. So there's things that I think anybody who prescribes this drug should be expected to tell, like that this will cause changes to the appearance of female genitalia. It will cause clitoral enlargement. It'll cause different patterns of hair growth. It'll cause different engorgement of different types of, or the arousal stimulus is going to change. But that you were seeing them because of complications, and you're describing pelvic pain. So I think this highlights one of the things that I've been critical of in terms of how gender care is provided, which is that the demand for gender care has risen so steeply, and particularly around natal females, both adolescent and young adults, people, let's say, under the age of 29, where for whatever reason, and maybe it doesn't need to be the focus of today's show, but there's been a rapid increase. This used to be the domain of specialists. So people who would exclusively focus on trans care. People who are trained in trans care who presumably also would be more informed about both the benefits and the potential side effects or complications that can result from going on this therapy. Some of these results, of course, we might think of as complications, but the patients, these are things they want. I'm sure many of these people may have wanted to see changes in the appearance of their genitals, or changes in their bodies, but that have side effects. And when this was done by experts who were seeing exclusively these patients, or most of these patients, they probably got counseled better about the risks and benefits. But what I think ends up happening when something increases in incidence is there's an expectation that non-specialists are going to take on more of the care, and that the screening process goes down because you just don't have the capacity. And there was also a push towards doing less screening because everybody's valid. And so you have people who are walking into, especially adults, who are walking into primary care physicians who might have some knowledge, but not the same degree of knowledge as let's say a board certified urologist or an endocrinologist would have about this, and develop complications, and then they're kind of like shrug their shoulders. Now, the reason I bring this up is because this is medical practice writ large. I'm a specialist. I see a lot of patients where the diagnosis seems obvious, or where the physician hasn't told them, oh, if you start this drug, this thing might happen, or if you have this condition, you should expect to experience this. But my response to that often is, yeah, I guess so. Like, there's too many patients, primary care doctors overwork, they're not bad people. And my job as a specialist is to deal with that kind of thing because I've got specialized knowledge, and sometimes my job is to be the one to say, hey, that's to be expected. Yeah, you're going to see, like, in my case, there's a drug called 5-SA, and because it's in a capsule, it appears in people's stool, and people see it and they get freaked out and they come to me, and I'm like, yeah, that happens. And I know that's a relatively basic thing, but part of me is just being like, well, isn't that our job as a specialist to say, yeah, this happened. Your primary care doctor can't know everything.
Yes and no.
Okay.
Because there has to be some responsibility somewhere. If you are going to provide a service, I feel very traditional sense that if you are going to provide a service and give particular drugs, or you are going to provide a care to a patient, you should know what you're doing, and you should know the ins and outs of that particular treatment or medication. You should be very well versed in those things and not just write the prescription because you can to appease the patient. But if you don't know what you're doing, then get that person to somebody who does know what they're doing. And that's my big problem with what's going on.
Yeah.
There are too many cooks in the kitchen, and not enough of them know how to cook. So, they're creating a lot of issues, and not giving proper informed consent. And I'm a big informed consent person. When I do surgery, I will, if I'm reconstructing a pelvis for a dropped bladder or a dropped uterus or, something for reconstruction, I am sitting there with that patient saying, this can happen, this can happen, this can happen. There are also other things that can happen that we may not talk about or we may not foresee. There are these other things that you may experience. However, we're going to work through this. We saw the same thing happen with transvaginal mesh. The companies put this transvaginal mesh in these great little kits so that Joe Schmo urologist or Joe Schmo gynecologist could perform these procedures. And what happened was not everybody should have been performing these procedures. Yeah. They were weekend warriors. They would do a weekend class. They would work on cadavers, which, that's a great thing, but that's also not exactly representative of actual tissue that you're working with during surgery. And so then we saw all of these complications. Well, what happened? Transvaginal mesh got the bad rap when it was actually how it was being packaged and marketed to people that shouldn't have been doing it to begin with.
Yeah, so this is something like I broadly agree with, and because I think you bring up the example of transvaginal mesh, and we see examples of this all over the place in medicine, where demand outstrips specialist supply. People are given the impression, both physicians and patients are given the impression that this is really easy, and I think this happened in trans medicine too, which is that people said you don't really need to diagnose people. If someone says, if someone identifies this way, we believe in bodily autonomy. If someone wants to take estrogen, if someone wants to take testosterone, that should be their right to self-actualize, and we should primarily be facilitators of their self-actualization, which I think is
what happened with the opioid crisis when that happened. Yeah. Whatever somebody says pain is, that's what pain is, and it should be treated. Yeah. Same exact sort of thing.
Yeah. But I think where you and I agree, and one of the points of agreement I really want to focus on is the area that is the problem is the practice. People are told it's easy. People are told you don't need to do screening. You don't need to do this. It's anybody can do this. You can learn it in a weekend. You can make whatever. You can go to a weekend and take a continuing professional development course and get a little certificate that says that you can do this. And all of a sudden you've got business. You've got and people come to you because they realize, okay, this is a person who is making it easier for me to get on something that is important to me. And probably a lot of people, even with that kind of lax system, do fine. But there's an increased chance that people don't, and then they come to my office, or they end up in my office or your office. But the point is is that when I see this, it tells me, just like you said, it's not the problem with the mesh. It's the problem with how the system is set up around who gets the mesh and how the mesh is put in and who's dealing with the complications. But I would make the same argument for transcare, which is the problem is not so much transcare itself, that it can be done well if it's done by experts who are doing appropriate screening. And I have quibbles, I shouldn't say quibbles, I have problems to some extent with how care is being done now, because I think people are running into trouble. Even if, and I believe this, the vast majority of people are happy and great and satisfied, the people who aren't it creates a lot of problem in their lives. And they also become people who, and I'm sure this happened with vaginal mesh too, probably a lot of the people who were looking for it to be banned were the people who had horrific complications from it. Would that be accurate?
Yes. But we as providers also need to be bold enough to tell patients this is not what you need right now. Maybe you need it, but let's explore what's going on. And I would do that a lot when patients would come in and they would say, oh, I need this surgery because X, Y, and Z. And then I examine the patient. It's like, well, you've got a couple of other things going on. I'm not so sure that's exactly what you need right now. It might be something that you need in the future, but let's try this first. And let's explore this a little bit more first and see if this corrects the problem. And I feel like that's much the case with transgender medicine. And again, without going into why we've seen this explosion, we have seen this explosion of individuals seeking care or seeking medicalization, surgery, or, or hormones. Is that exactly what they need? So much has not been explored before the medicalization process happens. It's just, oh, here's your prescription for testosterone. Here's your prescription for estrogen. Let's not take a look at what else is going on. Let's not get to the root of the problem. Maybe this is what you need, but not while your brain is still developing, not while your body is still developing. Maybe this is something that, later on, when everything is figured out and everything is normalized and we've actually gotten to a level playing field to suss out what the real source of the issue is, maybe it is that you need these hormones or you need this surgery. But let's explore what else is going on first. And I think because, and this is purely my opinion, again, I think from what I've seen and from experience, providers are practicing defensive medicine instead of being providers and looking out for the patient's best interest before sending them down a potentially irreversible road.
Have you seen the results, like in people who were given cross-sex hormones as minors or had their puberty suppressed and then cross-sex hormones as they've gotten older? Have you seen issues that has caused?
Oh, yeah.
What have you seen?
It's very, very real. Heart attacks, diabetes, osteoporosis, joint pain, muscular pain, increased mental health issues. So, I mean, the list goes on and on. When you start manipulating systems that are designed to function one way and you start influencing those systems in the opposite direction, there are a lot of risks that come along with that, that patients are not being told about. And if the providers are going down this road with a patient, it truly should be a partnership. The patient is just as much responsible as the provider is, because this should be a joint decision between the provider and the patient, where there has been a long-standing rapport developed. The provider builds trust with the patient builds trust with the provider. I mean, that is the premise of traditional medicine. You have a patient and you have a long-term relationship. You know about this patient. You know about their medical history, not a 15-minute appointment with a new patient in the office and here's your prescription. Especially for medications that have this sort of ramification.
Yeah, so I agree with some of the principles there, that that when we try medications, we should be informing patients of both what we know about and also what we don't know about. Because I think with a lot of hormone therapy, obviously I think we're physicians, we see the complications, and the complications are always very memorable. We don't see all the healthy people who are perfect, who are fine, who haven't developed complications. They don't find our way into our office. They're too busy sitting on the patio enjoying drinks or raising their kids or doing all the kind of things that don't involve them showing up, with complications. But you're right, complications can occur. And I know when you look down a product monograph of any new medication, you get a list of all the things that have happened even once in the clinical trial, at any dose. Those get listed. And when I'm starting someone on, I prescribe highly consequential medications, often for long term as well. And these are medications that haven't been around very long, where haven't been given to very many people, where I have to tell them, as part of the informed consent process, part of the informed consent is and I tell these every patient is, I don't know what the long-term side effects. I can't tell you in 20 years if this is going to increase your risk of heart attacks or decrease your risk of heart attacks or have no effect. I can't tell you whether it's going to give you cancer, not give you protect you from cancer, or have no effect. There's a lot of things we just don't know because this drug is new. And I can go through the things that we have learned about from the clinical trials, or from my clinical experience of, like you're starting this drug, there's a 20% chance you might get acne. There's a 50% chance you're going to feel fatigue. Like those kind of things that I can tell them, and I share your concerns that we have demedicalized or deresponsibility the prescribing of hormones, because there was this principle of it's your body, you should be able to do whatever you want with it. And also I think there was this presumption that, and because I think a lot of our information and a lot of what we believe to be true emerged from studies out of an era where there was more gatekeeping, or at least more assessment, and more comprehensive follow-up, and more specialist follow-up, that didn't necessarily translate to when this became democratized, in a sense, where everybody became a specialist in this type of medicine. And also because we've been doing it for years through this specialty, by specialists, and people seem to be doing largely well, we extrapolated that this new cohort of patients would do equally well. Now, you mentioned the mental health challenge of things, because one of the things we know about the new cohort is these are not people who are high functioning exceedingly well mentally prior to therapy. And not just because of their gender dysphoria, they often brought with them a lot of mental health comorbidities. So these were the kind of people who were coming to the hospital and getting hospitalized for depression, anxiety, obsessive compulsive disorder, disordered thinking, suicide attempts, or severe depression, eating disorders. I can make a long list of all the things that people who have gender dysphoria also seem to have as well. And so when you're seeing a lot of these things later, it's always unclear whether you're dealing with pre-existing risk, baseline risk, or the impact of the hormones. And the reason I'm pushing back a little bit is that often we talk about them like these are known complications, or that they happen, or that we talk in a way that makes them come across as though they are inevitable. Like everyone who starts on testosterone is going to develop all these bad things, when the reality is, at least my reality, or my understanding of it, and I recognize data is incomplete here, is that most people are fine. People have minor, might have minor things. Like I've had surgeries, I've had minor things, but overall, I'm pretty happy that I've had it. How is there, like, how should doctors, like, how would you want doctors to optimally communicate about this?
Well, I want to go back, first of all, to something that you had said about, yes, these individuals often bring, some sort of mental health baggage, if you will. There are these pre-existing conditions. But we don't see osteoporosis and increased heart attacks and increased diabetes from things like gender dysphoria and depression. Those are very real complications, known complications of hormones. Mental health doesn't cause diabetes and some of these other issues, the osteoporosis and things like that we're seeing. So I want to draw a clear line between mental health issues and the things surrounding mental health issues not being addressed and effects of drugs and surgery, because those are two entirely different realms. So the way I would see, an answer to your question of how I would want providers to, and how I feel that providers should best equip, yes, there are no good studies because we don't have them. There's no way to track these individuals to know, what the effects of puberty blockers are going to be, for instance, in children 20 years from now. We know what it does to adult men whom I put on Lupron for prostate cancer. We know what that does. We know. But there are no studies on this for children. So to go to parents and say, this is completely reversible. You can't
I think
say.
we're conflating two different things here, because you're right that there may be an increased risk, let's say, of let's say osteoporosis, but like, what is the relative risk? Like, if because like we can list and say all these things can happen, but it really matters. Does this increase your risk by 20 times? Is this increase your risk by 20%? Those are very different. Those are, and some of these things are okay. I accept that if I go on testosterone as a dysphoric natal female, that I'm taking on some risk, and part of that risk is like the risk of being male, or being more hormonally male. We know that men get more heart attacks and they get them sooner, and men have a shorter lifespan for all sorts of reasons. How much of that is the aggression that testosterone brings to puts your body, and deaths of misadventure when you're young, as well as deaths from cardiac disease, from cardiovascular disease when you're older. Those things are known. And part of this is, if you're someone who's going to be a long-term transitioner, you're taking on the risks that come along with having a male physiology. And you get that. And you say, okay, I would take on those risks because it's very important for me to live in this social role. Some of those risks are within acceptable ranges, that you might have to deal with this if you really want this life. And patients being autonomous, we say, okay, you can do that. Other things are kind of really, I have to admit, are kind of speculative. I think they're important to mention, things like osteoporosis, but what would you say the relative risk of getting osteoporosis, not from Lupron, but from long-term testosterone is?
Yeah. So again, depending on whether that is a child, and that's what I was trying to get to before, whether that is a child or whether that is an adult, we don't have these studies if somebody starts this as a child. So the only studies that you can quote would be for adults. However, this is the unknown. If you are subjecting children to this, their bodies are still growing. So I would speculate, not having, and this is opinion, I would speculate that it would be greater risk as an adult seeing these ramifications, because you are influencing a body that is still growing, and you're halting processes in a body that normally should be developing developing in ways that prevent these things, in the future. So if you are influencing hormones, while these tissues and while the brain and while the endocrine system is still developing, that is the unknown. And that is what doctors are not telling patients. You can't give a patient a relative risk. You can't.
Yeah. And I
because
can't either for a lot of
there are
things.
no
Yeah.
studies.
Yeah. And you're right. This is medicine where there's always going to be more you don't know than what you do. And like you said, a lot of our counseling is about the uncertainty, about I don't know what this is going to do, but I also don't know what, like I think the traditional line of argument always been in terms of people supporting this in good faith has been like, I don't know what the impact I can tell you how your body's going to develop, if we let puberty, continue, but what I can't tell you is what's going to happen with your dysphoria and how that dysphoria is going to impact your future mental health. And it's so I recognize, the arguments around this, but one thing I wanted to sort of, lead into, because you're a surgeon, you probably see surgical complications of surgical misadventure as well, or of have you in your practice manage, were you at one point, I don't know if you still do, seeing patients who've had, let's say, phalloplasty or other bottom surgeries, or even vaginoplasty in male to female transsexuals? Were you in your practice seeing those kind of complications as well?
Yeah, we would see them. And, it's funny because I would oftentimes wonder, was this just my experience as a surgeon? Was this just my experience because I would see patients with this sort of thing? How rampant was it? And being at GenSpect last week, or 2 weeks ago, and speaking with detransitioners, and particularly detransitioners who had undergone some sort of augmentation of their, genitalia, there was not one of them that did not have a complication. There was not one of them.
You're talking primarily like phalloplasties?
All
of them.
Both males and females.
Yeah.
There was not one individual that I spoke with that did not have one or more complications from augmentation of genitalia.
Yeah.
And so that just reinforced to me that it wasn't just my particular little world that I was seeing in practice. This is true with, I love to go to meetings because it allows me to see if what I am experiencing or what I was experiencing in private practice was just in my little part of the world, or if this was a more widely experienced circumstance. And the same thing happened with GenSpect. It again reinforced to me that it wasn't just
what's coming into your office.
What's coming into my office. This is a general sort of thing. There certainly are those patients that do well and don't have regrets, or if they do have regrets, they're not going to the providers and to the doctors because of it. There are always those individuals, but what we're going to find out in the next coming years is just how many complications are going to crop up, and thus again brings us back around to why we need ICD-10 codes and being able to track this, because we don't know how rampant it is, or lack thereof.
Yeah. So I kind of agree that, like, in general, that we always want better numbers. We always, because we don't want to rely on our anecdotal experiences. We all know this as physicians, that we often see the worst of the worst. So we see especially if you're in a surgical specialty, you see the complications, and if you're highly specialized, which it sounds like you are, you see the complications of other surgeons. so if that's all you're doing all day, you're right. You get a very skewed view of both the things that seem to happen all the time, which maybe on a population level, because they may happen 1% of the time, but they're all being filtered to you. So in your office, you look like 100% of the time. And also the really rare things that do happen often leave a mark where it's like, oh, someone had this really idiosyncratic, strange reaction, and I'm not using, like, if that's your first time using the drug, you're not using it again. But you sort of allude to it too. You're also at a Gen Spec conference. These are people who are generally regretful about the experience of having transitioned and are reporting outcomes that are real. But the contrast is, like, if I'm bringing this to my own life. So I've had bottom surgery. I had it 23 years ago. I am exceedingly satisfied with the results of my surgery, while also accepting that there have been complications. And these complications have been minor. They've been nothing that's put me in the hospital, nothing that's threatened my health, but sort of things that are like, it would have been nicer if it came out slightly a little more this way as opposed to that way. I'm not 100% satisfied. I wish the whole surgical technique was better overall. But if you were to ask me, do I regret? Or did I understand these things could happen? And I kind of was like, if they happen, but I want this procedure done. And it's brought a lot of intangible benefits to my life, then I would still say those can both be true. So the kind of complications that, and I know we didn't get into specifics, there's probably a lot of people who are walking around with those complications, but are kind of like, well, it's certainly better than what I had before, or it's better than the life I had before. And if this is the cost of getting rid of my dysphoria, or bringing my body into alignment, or of giving me sexual function in a way that I wanted to have sexual function, then I will put up with whatever, whether it be a misdirected urinary stream, or whether it be spasms every once in a while, or whether it be that I have to go to the gynecologist and have something done every few years to restore vaginal health or neovaginal health. Like, those are just kind of things where it's like, okay, well, that's part of the bargain. And so I guess how do we square those numbers? Because you went to a detransition conference. If you happen to have wandered into a WPATH conference, or to some other trans support conference, you probably would have got a very different narrative, no?
Probably so.
So we can't go on narratives.
Right.
In the absence of the data, of the hard data, like the cohorts are followed very closely for a number of years, where you get a lot of good reporting, and you could say, okay, there is a 26% chance you're going to develop this, or a 48% chance you can develop that. We still have to find a way, or I think we still have to find a way to talk about this with patients, as opposed to just saying, well, complications, we shouldn't do it.
No, if you can give informed consent, and somebody is able to give informed consent, which, by the way, I want to point out the things that you mentioned, of the things that you personally are living with, those aren't complications. Those are not complications. Those are things that naturally go with the territory, meaning, any postmenopausal female will have some misdirected urine stream, or vaginal atrophy.
I just talked about it because those are mine, as opposed to, but I know other women, and I'm friends with a lot of trans women who've had more significant, stenosis that prevents them from having penetrative sex, who have not just misdirected, but have to take 5 minutes every time they go to the bathroom. Meaningful, impactful complications. But if you still take back, is like, do you regret having the surgery? Do you wish you had your original parts? They're like, no, blank and way.
Yeah. And women, women and men live with those sorts of things. I mean, and I saw that a lot with the restorative surgeries, from restoring, dropped bladders and dropped uteruses and things like that. I saw those things, that the patients would say, yeah, it's much better to live with, needing to, take this to facilitate bowel movements, as opposed to what I was living with before, and not. So it's relative to what the patient perceives, and we see this in studies all the time. How do you quantify satisfaction for a patient? A patient may come in and we may examine them and say, "Oh, your bladder has dropped again, so you're a failure of surgery." When in fact the patient is satisfied because their bladder was completely hanging out of their body before, and now it's just kind of dropped down. So is that a whose perspective, in whose perspective is this a failure?
Yeah.
So I'm more concerned about honesty with the patients and patients being able to make that informed consent, to be able to say, yes, I'm willing to live with these particular things, but yes, I understand that, if I have a vagina that is formed out of bowel, instead of another external tissue.
Relatively rare, but yeah, people that sometimes happen.
Then, if I have this, then for the rest of my life, I'm essentially going to have an open wound that's going to be predisposed to different types of bacteria than what a native
It's not an open wound. It's a surgical anastomosis. You wouldn't describe any other surgical anastomosis as an open wound. I don't recognize, yes, it is bowel tissue. It might affect the microbiome in ways that we don't totally understand. People do need to, if we're going to be honest, people do need to come in for things like colorectal cancer screening if they're older. I do some of those procedures. But I think the point we're wrapping around to is that as long we both want, I think it puts a stain on transgender medicine that people are not getting properly counseled about the implications, good and bad, of these surgeries, and that these things might be delayed for many years, and I can't even tell you if it's going to happen, and it's important that we keep ongoing care, and you may need to see a specialist. I think that's all important things to tell about, to talk about patients. But as far as the surgeries themselves, that are, you do surgeries that are very anatomically complex. There are going to be sometimes things that don't go exactly the way you want them to, and also just reconstructing a pelvis is, you probably can never make it whole again to the same way that it was, let's say, that you were born with. And we accept that that's going to carry with it some complications, but we're both, I think, diligent people who really make sure our patients are as well as informed as we can be about those certainties and uncertainties. One last thing, because I know we have to wrap up, and I want to bring this into the pediatric realm a little bit, because I think we've talked a lot about issues of consent today, and those issues are more complicated when you're dealing with people whose brains have not fully developed, and whether you draw the line at 18 or whether you say it goes even further, because brains, we recognize, are still developing even after many people after that age. But we're both people who deal with sick kids, or maybe not the focus for practice, but we know sick kids exist, and sick kids are often faced with consequential medical decisions, and their parents are often faced with consequential medical decisions where there are a lot of unknowns, and where both with having the surgery or not having the surgery, what medications you would use if you didn't have the surgery, what the natural history of the disease is if you don't have the surgery. And parents and kids have to make those decisions. And I know gender is a different thing, because it's not like, if I talk about cancer surgery, is obviously, no one's going to say, well, you can just live with your cancer. Kids can't make decisions, so we'll just wait till they're 18 to deal with their cancer. Everybody knows that's a dumb argument. Or only dumb people make that argument. But I'm going to give you an example from my practice that I see, that it maybe isn't exactly like gender surgery, but comes close. I see patients with ulcerative colitis. It's a disease that affects kids. And so 20% of the time it's diagnosed before the age of 18. We try to treat with medical therapies, but a lot of people don't want to use these medical therapies because we don't know the long-term side effects of them, and kids are developing, and we don't want to expose them to immunosuppressants and all sorts of things. Many of these kids end up having surgery for their colitis. That surgery is a cure. They won't get colitis afterwards, but they'll be left with an ostomy. An ostomy is obviously artificial, but it functions very well. My patients with ostomies, I almost never see them because people learn to live with them. They don't get infected. They tend not to get inflamed. They don't get recurrent disease. But what we often offer kids is a different thing. We offer to reconstruct their bowel and to close their ostomy and to reconstruct their bowel to bring it to continence again. And people want this because people don't like this idea of having this ostomy, and people want to poop normally. But similarly, everybody will develop some complication at some level, mostly mild, and some of them severe. 10% of them will want it taken away within 5 years. That's substantial for a surgery like this. When you ask people if they're satisfied, and they've done pretty good studies in this 20-year cohorts from the Mayo that show like 90+% satisfaction, which is sort of similar to what happens when you ask trans people if they're satisfied. But when you dig deeper and say, like, are you having any problems with this? Most people will also say, I don't like this aspect of having it. They say things like, if I could have it done again, I would go to a different surgeon. Or I would maybe have seen if I could live with my ostomy. They're still satisfied overall, but they express, to some degree, regret or dissatisfaction. Like they're not happy. I think maybe a quarter of the people who have this describe their function as optimal. Yet, if you're a 15-year-old, or if your parent's a 15-year-old, and someone says, I want to give my kid this very consequential surgery because I think it's going to improve their quality of life, nearly every doctor is going to say, yes, this isn't controversial.
But normal development is not pathology.
Correct.
Pardon?
Normal development is not pathology.
Correct. We're talking about an elective procedure versus procedures for a pathological condition. Gender dysphoria and surgery to augment a body is not you're not having surgery for a pathological condition.
But the consent issue is the same. You're doing a highly consequential surgical intervention. I'm just talking about pouch procedures here.
Mm-hmm.
You're doing a highly consequential surgery that is elective. Nobody will die for lack of having a pouch procedure. People can live with their ostomy and live a high quality life with an ostomy. The kids cannot possibly understand all the things that might happen down the road with their pouch when they're 20 and 30, and the implications of that. Most will still end up saying they're satisfied. I know it's not the same surgery. The indications obviously are different, but what I'm saying is in one situation, there's no hue and cry about kids can't consent and they don't know what they're getting into, and maybe we should wait till they're 18 or till they're 25 to decide about their ostomy because they have no capacity or limited capacity to understand what the long-term implications of this highly complicated surgery is. No controversy. So I guess my question is should there be more controversy about surgeries like that, and maybe we're being blasé about pouch surgery, or is there a reason why we're allowing kids and their parents to provide consent for these highly consequential surgeries in one case and not for the other?
Because one's reversible and one isn't. Because you can always go back to an ostomy. Once you augment tissue and normal genitalia, there's no going back.
Yeah.
So we're talking about complete apples and oranges. I understand the informed consent, and you're talking about informed consent and not possibly knowing complications of a pouch and things like that. But you can always go back to an ostomy. That is a perfectly reversible. You can go back to
not
that.
Perfectly, but it is technically.
But you can go back to that once you augment genitalia. Once you chop off healthy breasts, there's no going back from that. There's no that. So from my standpoint, that's not even a comparative argument, because we're talking about pathology versus something that's not pathological, something that's purely elective, and augmenting perfectly normal, healthy tissue in a way that you're never going back from that. Once it's augmented, you can come back to something with some semblance, but it is never going to function the way that it was meant to. So from my standpoint, respectfully, that particular argument is yes, to elective procedures, but to elective procedures for entirely different reasons.
Okay, so you're okay with kids giving informed consent for a highly consequential procedure because it's potentially reversible down the road, uh, in that situation. So kids can consent for, or kids and their parents can consent for some highly consequential procedures that are elective.
If they are elective and the child has the opportunity to go back to an ostomy, again, you're talking about informed consent, about unknowns. And yes, there are unknowns, but you can always go back to an ostomy. So regardless of what those ramifications are later on, you can always go back. You can always reform. So you can always, do away with the pouch and go back to an ostomy. So the problem that I have is the bit of the twisting of, so children have informed consent for this, but not for this. Again, two entirely different arguments, two entirely different things. One is something that does not have long-term ramifications to the extent of altering a healthy body. We are talking about informed consent for altering a healthy body that does not need to be altered to begin with. That is generally for the most part, somehow in some way tied to a mental health issue that has not been formally addressed. And for normal healthy function later on down the road, children cannot consent to that. For an ostomy, normal healthy function down the road, yes, you can have healthy function down the road. So again, one involves emotional manipulation of a parent, and one involves asking a parent and a child, do you want to try this with the understanding that you can always go back? Once you've gone down that road, you can't go back. So the issue that I'm having with this particular argument is that they're not equal arguments.
Yeah, I recognize when you're dealing with analogies, there's no perfect analogies, and I think these conversations help help explore it. So, Dr. Crites Bachert, I like I said, I really appreciate you coming on. I know that
for the opportunity.
Yeah, I know. Being on a show where maybe getting asked a little more pointed questions is always a little more adversarial, but I think it also helps really elucidate a lot of the issues
Absolutely.
in these contentious areas. And I really appreciate and respect you for coming in and sitting down with us. And
Absolutely. And that's the
being open.
way we, agree to disagree, and we act like adults, and we have these particular conversations and listen to each other's points of views. That's how things get done.
I agree. That's something I'm not going to agree to disagree, but just generally agree on. I know our audience is going to hate this because I know because of this like physician stuff. I took a little bit more of the initiative. Is there anything you want to say before we close?
Oh, I love these conversations because more and more nuance comes out when it's not just the name calling and everything. Then there's more gray area. I saw that the two of you did agree more than I thought you would. There was more overlap than I expected, which I thought was really, and I learned a lot too.
Yeah. No, I know it's easy to focus on the disagreements, and there were some, and there still are. But
Sure.
Like I said, I think if I could sum this up, like I think the informed consent issue is really huge, and the fact that people were practicing probably outside of the realm, maybe out of perceived necessity, but still with the intended results, is something that people like me who actually want the project of gender medicine to continue need to deal with. If we're going to make the case to skeptical people that we're doing this responsibly, we need to actually make the effort of doing it responsibly and not just assuming that anybody who takes a weekend course can do this, or that anybody can just do this and you'll be fine. Are not the ways that we can continue to practice going into the future if we want to maintain the support of the population and of our lawmakers. It's just not tenable unless we solve that problem. All right, so thank you very much. And this, I think, is going to be a great show. I think we're going to get a lot of audience engagement on it. And once again, thank you for coming in.
Thanks for the opportunity.
Yeah.
All right. Take care.
You too.
Bye-bye. Bye.
That was fun.
Yeah.
Like I said, like this is the whole point why we're doing it. We disagree on a lot, and we could have probably gone on for a few hours about all the different ways we disagree on it. We have to have a tight show. But if we don't talk about it and we don't put these arguments out there, and like I said, like these arguments are ones that different people are going to answer differently and explore in different ways, but this is how we talk through an issue. And like, when she's talking about it, I thought that was a really solid point about the reversibility being different, but also that and it also, I think, undermines a lot of the very quick, like when people just shout, kids can't consent, what we're really saying is kids can consent for some things and kids can't consent for other things. It really is the nuance that defines where we think we draw that line. And I think exploring those edges is really important. Like we admit for cancer, yeah, we're not going to let a kid not get chemotherapy or remove a tumor because kids can't consent. But there's other things where where it's not quite as black and white that are worth discussing.
Sure.
Yeah.
Sure. No, I thought it was really a very good conversation, and I love bringing in different kinds of experts from different arenas.
Yeah, like I said, there's a lot we didn't get into, but she's clearly someone who is well trained, who is doing important work, who is dealing with people and undoubtedly dealing with people who are having complications. And like, it's like, I know we're physicians, we see complications, they tend to have a disproportionate impact on us, but it matters. Like we need to be talking about these things, and we need to be talking about these things both because as someone who supports this, I want to make it better. And I want my patients to be better informed and making better decisions so they don't end up at GenSpec conferences, so that they either never had it to be. No, exactly. But seriously, I'm sure everybody in that room wishes they weren't there. Right?
Oh, absolutely.
Yeah,
absolutely.
They wish that they never had heard of gender medicine. And I ideally don't, like, those are people that I wouldn't have wanted to have transitioned either if this was going to be the outcome. We want to minimize this. And we want people to be better informed, making better decisions so they don't become regretful transitioners. And we can focus on the people who've really been thoughtful about this and who are going to have the best chance of doing well.
Yeah, no, I can agree with that.
Yeah. All right. Well, great talking to you again. And we will see you at our next episode.
Fantastic.
All right.
Take care.
Bye-bye.